Hello everyone, I'm Dr.Rabika Rizwan. Today I'm going to talk about ECV, that is External Cephalic Version. In order to get a good concept, you need to understand what, when, why, where, and how about ECV. Now, one by one, I'm going to explain these what, when, why, where, and how to memorize all about ECV. As you all know, with advancement of pregnancy, the baby keeps moving and continuously changes its position in a different manner. The most common and the most helpful position by the end of pregnancy, close to delivery, is cephalic presentation, that is, head down position. However, another common presentation is breech presentation, that is, bottom down position, in which the buttocks are facing towards birth canal. Almost 3 to 4% of term pregnancies are in breech presentation. To manage breech at or near term, we can either plan breech delivery or breech extraction, which means delivery of the buttocks first, followed by the rest of the body, and the head delivers at the end. Or we can do cesarean section. And the third choice to manage breech pregnancies is external cephalic version, which is my today's topic to explain. External cephalic version is a physical manipulation to rotate the baby from breech presentation to head down position externally through abdomen. It increases the likelihood of normal vaginal delivery with cephalic presentation. The first W for ECV is what, which means to think about what are the contraindications and prerequisites to perform ECV. Talking about contraindications, we have absolute contraindications and relative contraindications. Absolute contraindications mean that you can never perform ECV if you encounter a patient with these conditions. Point number 1, when SVD is contraindicated, that is every patient with previous 2 or 3 cesarean sections, or primary breech, or placenta previa type 4, in which you cannot plan normal vaginal delivery. Likewise, you will not consider external cephalic version. The second point is antepartum hemorrhage within last 7 days. The next point is abnormal CTG, and then we have major uterine anomalies, that is uterus didelphus, septate uterus, and the last contraindication is multiple pregnancy in case of twins, triplets, or quadruplets, except second twin delivery. That is, when the first baby delivered in a cephalic position and the second one is lying in a breech presentation, then you can plan external cephalic version for the second twin. The relative contraindications are small for gestational age baby with abnormal Doppler, preeclampsia, that is high blood pressure along with proteinuria, oligohydramnios, that is reduced amount of liquor around the baby, major fetal anomalies, scarred uterus, that is previous one lower segment cesarean section. As you can see, the guidelines recommend us to consider external cephalic version in a patient with prior lower transverse cesarean section. So it is not a contraindication. Next, relative contraindication is unstable lie. And the last point is macrosomia, that is fetal weight more than 4 kilograms. Now, if you see a patient with these relative contraindications, you have to be careful to perform ECV. You may end up on a cesarean section, as the chances of successful ECV are not very high. However, absolute contraindications say no to perform ECV. Considering all these points, now we understand that we cannot rotate the baby from breech to head down position if the baby is IUGR, that is growth restricted baby, with abnormal Doppler ultrasound values, raised SD ratio, absent diastolic flow, reverse diastolic flow, or the mother is having high blood pressure with symptoms for imminent eclampsia, or the baby is abnormal with any kind of abnormality, that is high drops, anencephaly, and then reduced water bag is not a good and healthy point for ECV, and lastly, good size baby. What are the prerequisites to perform ECV? This is the favorite question to be asked in your clinical exam. It simply means what is the environment in which you are going to perform external cephalic version. When you have decided to perform ECV and you selected the most favorable patient in which you are going to rotate the baby externally, the first point and the most important point is hospital setting. You must perform ECV in a maternity setup or a hospital with immediate access to perform emergency cesarean section or even breech delivery. While performing ECV, you may face fetal bradycardia, that is poor heart rate of the baby, or maternal discomfort leading to placental abruption, or you may ignite normal labor. So you should be quite ready to perform emergency C-section or breech delivery. So always keep this thing in the back of your mind and perform ECV in that kind of hospital setup. The next point is keep the patient NPO nil per oral for at least 6 to 8 hours before. Of course, considering that you may end up on emergency C-section, you should keep the patient NPO. Then you need to do blood group cross-match, and most importantly, you should arrange anti-D immunoglobulins for Rh negative mother, as you need to give injection anti-D at the end of the procedure. If your patient is having negative blood group, that is B negative, O negative, AB negative, the next important prerequisite is the presence of anesthetist and anesthesia assessment. Again, this is needed for emergency C-section, so you should inform anesthetist prior to perform ECV, and anesthesia assessment should be done as a backup. Then the next point is ultrasound scan. And the important things that you need to see on ultrasound are type of breech. It should always be extended and flexed breech. As you can see in this picture, there are 3 types of breech presentation: frank breech, footling breech, and complete breech. Complete breech is flexed breech, that is hip joint and knee joint of the baby is flexed. However, frank breech is the baby with extended knee joints, which is not bent. To remember the types of breech, I am giving you one sentence to memorize. Frank is not flexed. F for frank, F for flexed. So frank breech is not a flexed kind of breech. Frank means friendly feet touching the face. Baby's feet are touching the baby's face. So this is frank. F, F, F. F for frank, F for feet, F for face. The next parameter to see on ultrasound is fetal and uterine anomalies that I mentioned before. Uterus didelphus, bicornuate uterus, unicornuate uterus, and fetal anomalies are anencephaly, hydrocephalus, fetal hydrops, etc. The next important point is fetal growth. It should not be too small baby or too large baby. Then liquor volume and placenta. It should not be placenta previa or anteriorly positioned placenta. And the liquor volume should be within the normal range. It should not be polyhydramnios or oligohydramnios. The next prerequisite to fulfill is CTG, cardiotopography, non-stress test. You should perform CTG for 30 minutes before the procedure and 30 minutes after the procedure. It is a documentary proof of fetal well-being. If you see poor fetal heart rates, fetal bradycardia, tachycardia, or absent variability or decelerations, you should not go on to perform ECV. The next prerequisite is tocolytic agent, that is terbutaline, 0.25 milligrams subcutaneously. It helps to keep the uterus quiet, and you can easily perform external cephalic version on a relaxed uterus. And the last important point is written informed consent. You should take informed consent in a written manner, including all the risks and benefits of ECV. Also, the technique of ECV should be explained prior to the procedure. Then the next W is when. When should you perform ECV? It is very common before 35 or 36 weeks of pregnancies to have breech presentation, as most of the babies turn to head down position before the last month of pregnancy. If it does not do so, only then you need to select a mother for external cephalic version. The best time to perform ECV is at 37 weeks of gestation or 38 weeks of gestation, not before that and not beyond that. Although you can rotate the baby before 36 or 35 weeks of pregnancy, but the baby is so tiny, so small, that it will come back to bottom down position the next day. So it will be a failed procedure. And 39, 40 weeks and beyond, this is too difficult to perform ECV, as there is not enough room to rotate the baby, and it can cause extreme discomfort to the mother also. So the good time is 37 and 38 weeks. Success rate that is mentioned in guidelines is 33 to 66%, approximately 40% in a nulliparous women, that is patient who is having first pregnancy with breech presentation, and 65% in a multiparous women, that is a patient who already has 2 or 3 babies before. The next W is why. Why should you perform ECV? Actually, we perform external cephalic version to rotate the breech baby into cephalic presentation, that is head down position, in order to facilitate normal vaginal delivery. It is quite easier to deliver the baby with head first. So it is most common and most helpful position. And of course, it is going to reduce overall cesarean section rate and associated morbidity and expenses with cesarean section. This is another point that is good about performing ECV. And the other most important reason is that we should perform external cephalic version to avoid breech delivery hazards. Sometimes it leads to bone fracture, collarbone, shoulder, arms, or even nerve injury due to excessive head traction. Then the next W is where. Where should you perform ECV? As I told you before, external cephalic version should be performed in a hospital setting or a maternity setup where operation theater and delivery room is available, where anesthetist is available so that you could do anesthesia assessment, where assistant or a helper is available. Although you can perform ECV by your own self, but sometimes you may need an assistant to stabilize maternal abdomen, to put a hand on fetal back, or to help your doctor for rotation. You should perform ECV in a hospital where ultrasound machine is available, as it is very important to see type of breech, water bag, baby's growth and size, placenta, and uterine abnormalities before performing ECV. The next important thing in your setup or hospital is CTG machine or non-stress test facility. Then you should have analgesics and tocolytics in your setup, as it is going to help to relieve maternal discomfort or any pain which can upset the mother and the uterus. The next point is how. How to perform ECV. 3 points you need to focus on: position of the patient, trolley, and technique. When you are done with ruling out all the contraindications and fulfilling all the prerequisites, the next important thing is to make position of your patient and to keep the trolley ready. It should be a supine position or Trendelenburg position. Supine means that the mother is lying on her back, straight on the bed. And Trendelenburg position means that the mother is lying with head down position, slightly inclined with feet or legs slightly higher. It can push the gut intestine back, and you can conveniently rotate the baby through abdomen, which is going to give you a room to perform this procedure on the uterus. Most commonly, ECV is performed with a supine position. Your trolley should be well equipped. It should carry gloves, gel, analgesics, that is painkiller, and tocolytics, that is the drugs to relax uterus. Now the last thing is technique. We have two techniques, forward roll, backward roll. When you're ready to perform ECV, ask your patient to lie supine, administer terbutaline 0.25 milligrams subcutaneously, then apply a good amount of gel on abdomen. It is going to reduce the friction while rotating the baby. Then expose your patient from xiphi sternum to pubic symphysis. You can put a draw sheet on chest and another draw sheet on maternal thighs. Now the first and foremost step is to disengage breech. Slightly push through the lower abdomen to disengage the buttocks from maternal pelvis. Only then you can rotate the baby easily. The first technique that I'm going to tell you is forward roll, which is also called forward somersault. If the spine and head of the baby are lying on the same side where the clinician is standing, that is right side of the mother, forward roll should be performed first, and if the fetal back and head are lying on the opposite side of the clinician or maternal midline, then you should start with the back flip first. Most of the clinicians tend to perform forward roll first, followed by backward roll. Here in this picture, forward roll or forward somersault is clearly shown, as the back of the baby and head are lying on the opposite side of the clinician or the practitioner who is performing ECV. So, forward roll is being performed. Make sure that you do not perform jerky movement. It should be a gentle movement. If forward roll is not successful, then you can perform backward flip. Now this picture is showing backward roll, and you can clearly see the fetal spine and head are lying on the same side of the clinician. And here the clinician is standing on left side of the mother. You can also perform external cephalic version if the baby is lying in a transverse position, and in fact it is comparatively easier to perform ECV with a transverse lie. And it would be the same procedure. After applying gel liberally, you need to gently rotate the baby towards a head down position. And here in this picture, external cephalic version is being actually performed on a patient. If the procedure goes unsuccessful, you may go for the second attempt at the same time, only if it does not give any discomfort to the mother and the mother is ready for second attempt. And of course, fetal heart rate are not compromised. Otherwise, you can consider expectant management, and you can even plan external cephalic version next week. But the clinician should perform cesarean section at 39 weeks or beyond if breech presentation persists. Now, what are the complications or risks associated with external cephalic version? You may have placental abruption, preterm labor, or premature rupture of membranes. That's why you need to perform this procedure in a hospital setting with immediate access to emergency C-section or even breech delivery. Then the next complication is cord entanglement or any kind of cord accidents. Then, most importantly, fetal distress, which is a very common complication associated with this procedure. Then, there can be a risk of severe maternal discomfort. And finally, you can have failure of version, which can even happen the next night or after a couple of days. I hope now you get a good grip on this topic. That's all about external cephalic version. Thank you very much.